Let me start by welcoming everybody to the first Berman Institute seminar of the academic year. As most of you know, we have these seminars twice a month. We serve lunch. We have a really, really great lineup of speakers all year, and it's fun to get the mix of topics that people discuss. Today we have the great pleasure of hosting Dr. Jason Schwartz, who is a brand new assistant professor at Yale in the School of Public Health. And with apologies, I'm going to read part of Jason's background to share with you so that I don't forget some of the important details. So at Yale, Dr. Schwartz, again, is in the Department of Public Policy, but has a secondary appointment in the section of History of Medicine at the Yale School of Medicine. He has written widely on vaccines and vaccination programs, which is what he's going to be talking about today. Before being at Yale, Jason was the Harold Shapiro Fellow in Bioethics at the Princeton Center for Human Values, and before that, Associate Fellow and Lecturer in the Department of Medical Ethics and Health Policy at Penn. He was also a staff member for the Presidential Commission for the Study of Bioethical Issues. Jason graduated from Princeton, where he received an AB in Classics, so we'll see what language he chooses to give today's talk. And went to Penn for both his master's degree in bioethics and his PhD in the history and sociology of science. His current research examines how policymakers, regulators, physicians, and patients evaluate and respond to the risk, benefit, and costs of vaccines, pharmaceuticals, and other medical technologies. Jason, welcome to Hopkins. I'm glad you're here.
Thanks very much. Everybody. It's nice to see a good crowd here. Thanks to Nancy for the introduction, and to Andy and Tracy for helping get the logistics in order to get me down here past the papal exodus in Philadelphia as I came from north to south here this morning. Just a few remaining pilgrims sort of stumbling around the train station as we passed through Philadelphia. So it's great to be here to kick off this seminar series. It's an incredible lineup they put together for the year. And I'm going to talk a bit, as my title suggests, about vaccination issues. And I could say it's an exciting time to talk about vaccination issues, but it's been an exciting 220 years to talk about vaccination issues. But particularly recently, the global front of the challenges around vaccine development and research for Ebola, the progress and challenges around polio eradication. But I'm going to focus on the U.S. front, where in the last several months we've seen outbreaks of measles in Disneyland and around the country, and the responses that have been considered in response to preventing future such outbreaks. We saw the unfortunate occurrence of allegations and controversies around vaccines surface in the most recent Republican presidential debate. So there's always a lot to think about and talk about around vaccination policy. And recently, sort of the trend, I'm wired so I can wander a little bit, the trend has been to think about the critical importance of what's happening in the doctor's office, the doctor-patient relationship, questions about how providers communicate with parents, for the most part, who will have questions or anxieties around vaccines. And there's a tremendous amount of work, some of it happening, I know, here at Dan Solomon, and a project he's starting that's going to look specifically at these kinds of encounters. And these local kinds of discussions around vaccine communication and vaccine promotion are critically important. It's not what I'm going to talk about today. I'm going to take a step back and talk about some of the policy level decisions and practices that ultimately shape the context in which those patient-provider interactions take place, the kinds of things that set the table for how vaccination looks and works in the United States today. So I have three miniature case studies, each of which could certainly fill our full time together, but I promise to be brief because I think the sum, hopefully, will add something in talking about issues in various corners of the vaccine policy world. Questions about how cost effectiveness does contribute to the way in which vaccination recommendations are developed in the U.S. Questions about how when and how we think about state vaccination requirements and how that fits into our ongoing story around human papillomavirus vaccine and the discouraging rates we've seen 8 or 9 years, depending on how you count since they've been introduced. And also a topic that gets a lot of attention recently and a lot of news coverage, questions about how we think about non-medical exemptions issues that maybe don't get a lot of attention, and hopefully perhaps some new perspectives on issues that do. And in talking about these topics, what I aim to do is to think about, as my title suggests, questions around equity. Really, questions around fairness would have been the more precise way, in terms of thinking about if we follow through the policies that we develop to regulate and promote vaccines, and we follow them through, what does it mean for how individuals and communities who stand to benefit from vaccines versus other preventive interventions, from one vaccine versus another intervention, or from the policies that promote high vaccination rates in communities, how do those policies treat some groups differently than others? And if they do so, do we have a clear and defensible way for how we treat these groups differently? That's sort of my focus that I'll try to build on as we go along through these three case studies. And I'll try, because I know I will leave time for questions and discussions as we go along. So first, the questions around cost effectiveness are interesting, and especially in the American context, in terms of vaccines and how we think about them. And where I want to focus is what, if you're a vaccine nerd, a group I affectionately include myself in, this is one of the more exciting world places to be 3 times a year in vaccine policy land. This is the meeting of the CDC's Advisory Committee on Immunization Practices. It meets in Atlanta 3 times a year, the group that is incredibly well respected, incredibly influential in setting the recommendations for childhood vaccines in the United States. And if you look very closely, you will see in this photo, the screen grab from the most recent meeting, a member of the Hopkins Public Health faculty who is in this room. And this person cannot identify themselves right now, because that'll ruin it. Do we see any of your colleagues here sitting around the table? I see people pointing to Ruth Karen, who is right there, I believe, a member of the CDC's Advisory Committee on Immunization Practices. These are the members who help develop schedules like this one. This is the gold standard, jointly issued with other professional specialty groups for when licensed childhood or adolescent or adult vaccines, for that matter, should be administered, and all the interesting complexities that go around. So the ACIP is a fascinating group to study and think about. It works very closely with its CDC sponsors and partners in developing these guidelines. And they have been, literally, if you trace the history of 20th and 21st century U.S. vaccination policy since they were established in the 1960s, you can not tell that story without the role of this advisory group, this group of esteemed public health, medical, research practitioners who support the work of the federal government in setting vaccine guidelines. This was a table from a 50th anniversary piece I wrote with my colleague Al Mahmoud last year, marking the 50th anniversary of the committee. And there's 2 things I want to note in the context of cost effectiveness. One is the establishment in 1994 of the Vaccines for Children program, a federal entitlement program that makes recommended vaccines for children or adolescents up through age 18 available free of charge for uninsured or underinsured children, Medicaid eligible, kids without insurance, Alaska Native, American Indian, and underinsured, which is a group that's shrinking now as part of the Affordable Care Act. But it's a large and critically important program that reduces costs as a barrier to access for childhood and adolescent vaccines. About $4 billion a year worth of childhood vaccines most recently now. So that's an important part where the ACIP, their recommendations and separate votes that they approve as part of their decision-making process adds vaccines to this program, independent of legislative action or any other sets of approvals. The second group of policies that has really given this advisory committee an important role, not just in evaluating evidence, but really a policy-making role, a delegated policy-making role, came to the Affordable Care Act, where, that's my next slide here, as part of the law's requirements, coverage requirements for preventive interventions, vaccines that are recommended by the ACIP automatically become requirements for new insurance plans under the Affordable Care Act, in the same way that other preventive services recommended by the U.S. Preventive Services Task Force, that other advisory group, I'll say a little bit more in a minute, it's gotten some attention for their recommendations on a host of topics in recent years. Recommendations that receive a favorable grade from the U.S. Preventive Services Task Force, or vaccines that are recommended by the ACIP are included as minimum coverage requirements for the ACA. So the schedule is an important technical document for physicians and providers independent of ability to pay, but through public programs like the Vaccines for Children program and now private insurance, the ACIP is a critically important group. A bit about these two groups that offer preventive advice, which lets me say a bit about this cost effectiveness piece, which I think is worth reflecting on. So we've got these two advisory groups that existed long before the ACA, and well respected and have been issuing reports and documents throughout their history, but they differ. They differ in their structure, who's around the table, literally, and how they go about their work. So the ACIP, as I know, I'm simplifying lots of complicated and sophisticated and successful careers into a few bullet points here, but we have people who are the national leaders in vaccines from all the various disciplines: state epidemiologists, medical researchers, infectious disease scientists, pediatricians, and related fields. People who are vaccine people first and foremost. They work very closely with the Centers for Disease Control and Prevention in terms of the questions they ask, the recommendations they craft. CDC participation is central to the work that the ACIP does, and their recommendations are issued. They're approved by the CDC director, but they're issued in the name of the committee. Compare that to the Preventive Services Task Force, which is the group that issues recommendations. We've seen the attention on screening mammography, on HIV testing, on other types of cancer screening, other types of prevention. A newer group, but a group that comes because of the fact that they work on a vast array of topics in prevention, variety of clinical fields. If you look at the biographies of their members, they come from a wide array of clinical specialties, but there's a strong focus on expertise in health services research or evidence-based medicine. These are people who know very well how to evaluate the quality of evidence on a preventive intervention and say whether the evidence is robust enough to make a recommendation that a preventive service is a worthwhile practice for a group in general. So a different kind of expertise, a different type of credibility and legitimacy in terms of how their recommendations are viewed by the communities who receive those recommendations. I think that's part of why Preventive Services Task Force recommendations have sometimes been seen as more controversial. When the recommendations around screening mammography were raising hackles in 2009, people were noting the presence of actual oncologists or other physicians who treat patients with breast cancer was very, very limited on the committee at the time. But that wasn't necessarily the skill set that the Preventive Services Task Force was tasked to do. Unlike the ACIP, which works very closely with the CDC, the Preventive Services Task Force was designed to be an independent entity. They're supported by AHRQ, the HHS agency that does health services research, supported in an administrative sense, but it's an arm's length relationship in terms of what the Preventive Services Task Force does, which is why, again, sometimes you see government distancing itself from recommendations. Again, the mammography example was a clear one. But cost effectiveness is what I want to flag as a distinction worth noting here, particularly as we think about the fact that favorable recommendations from either of these groups become insurance coverage requirements. U.S. Preventive Services Task Force does not formally include assessments of cost effectiveness in their recommendations. If it's there, they'll cite it in their recommendations, they'll know what the research is, but there isn't a threshold or a standard or a criteria where cost effectiveness guides whether the quality of evidence about routine HIV testing for adults 18 to 64 is a worthwhile intervention. They're not figuring costs into their recommendations. So if they recommend that it's a favorable intervention, regardless of cost, insurance companies will cover it, regardless of cost and regardless of cost effectiveness. ACIP, the story about cost effectiveness, is a more complicated one that long predates anxieties around cost effectiveness analyses in the United States and concerns about rationing and the Affordable Care Act debate. In the ACIP charter, at least for more than a decade, I haven't nailed down exactly when the language came into the charter here. The first paragraph sort of explains what they do in general terms, but it's that second line I want to call to your attention, that their deliberations shall include consideration of disease epidemiology and burden of disease, efficacy and effectiveness, safety, economic analyses, and implementation issues. And if you go to these meetings in Atlanta or watch their webcasts, they're very good about making their proceedings accessible. You'll see routinely, and have for well over a decade, so as long as I've been following them, you'll see routinely presentations by in-house CDC economists or outside individuals presenting the results of economic modeling, looking at issues of cost and cost effectiveness in supporting the committee's work in trying to develop the kinds of recommendations for how vaccines should be used in general or now how it would support the inclusion of vaccines in the Vaccines for Children program or private insurance requirements for the Affordable Care Act. So it's hard. So here, it's hard to assess exactly how great a role cost-effectiveness analyses play in the vaccine recommendation process over the last 15 years because there are no formal thresholds, there's not weighting, there's not the kind of process that we might be familiar with NICE in the UK or the vaccine folks in the National Health Service of the United Kingdom that do something very similar to what NICE does for other interventions. But if we look through the recommendations and deliberations of the ACIP over the last 15 years, these are some of the cases in which issues related to cost did play a role in the discussions. They were cited in the recommendations for the speed at which a vaccine was introduced, questions about numbers of dosing, questions about catch-up immunization programs. I'll flag the HPV vaccine recommendation for males when Gardasil was first approved for young men in 2009. The CDC and the ACIP moved rather cautiously in terms of fully endorsing routine vaccination for males. Part of it was because there were more indications coming, but as part of that discussion, these sort of lukewarm endorsement they gave for a few years were based on the fact that if we looked at the approved indications for HPV-related disease for males, and we looked at the economic modeling for that, it looked like, and was at the time, thought to be a better investment to focus efforts on vaccination of young women in terms of maximizing the benefits of the vaccination program generally. There were then expanded indications for males, and that sort of lukewarm recommendation became a full-throated one, for lack of a better word. Group B meningitis is the one where that screen grab was taken from. Most recently, I was at Princeton for the past few years, as Nancy said, and these meningitis outbreaks against serogroup B strains of the meningococcal bacteria raised great concerns on college campuses. We had these vaccines that were imported from Europe, then since approved. And right now, the question is evolving in terms of how these vaccines are introduced and rolled out. Again, cost is clearly part of the discussion. These are very serious but exceedingly rare diseases. And the cost of a robust vaccination program for every college student, in addition to other questions about what we know about the vaccines and what we don't, leads to some concerns about the scale of going all in on a vaccination program, specifically for this rare but serious group of meningococcal strains. All right, so when you ask folks, as I have, who are involved in these discussions, well, why is this group of technical advisors thinking about these complicated, contested policy questions around cost and cost effectiveness? You get a quote, you almost always hear a phrase like this, that the CDC and the Advisory Committee on Immunization Practices really takes its role seriously to be stewards of public health resources, that the money is not limitless, we all know that in public health, and the ACIP is trying to think sensitively to the fact that yes, we have this entitlement program for publicly purchased vaccines, but eventually that money has to come from somewhere, and the CDC and through it, its advisors are acting in good faith by trying to think about how we can best optimize how these scarce public health resources go. Now, all right, that seems like a laudable goal, certainly for medicine, regardless of how we feel about cost effectiveness. You can understand the motivation there to see how we can do the most good with what we have. Interestingly, when the VFC program was established, I pulled out an excerpt from the Statement of Congressional Managers in terms of sort of what the legislative intent was of the law. And you can see, hopefully you've been reading it as I've been yammering on here, that the idea was that discussions about recommended vaccines will surely have budget implications. The intent of Congress was that the ACIP's work be rigorously separated from such concerns. Conferees are troubled by past examples of budgetary influence in matters of science. And the idea was that even though, yes, this is a public program, we're entrusting decisions about this public program to outside advisors, it was specifically to sort of take these cost questions out of the picture. So on this one, I don't want to say much more about it. Hopefully we can talk more about it as we go along, but I want to move forward. There are these interesting questions to think about, saying, many of us would say, all right, bravo to the ACIP. I'm sure many of you in the room feel that, saying that yes, of course we want to do as much good as we can, but we need to begin thinking more seriously and responsibly about how we spend our healthcare resources. Point taken. The question I have is why we would think differently about how we apply those tools and those sensitivities to vaccine-preventable diseases through vaccines to all the other types of preventive services right now that the Preventive Services Task Force are responsible for that doesn't formally include cost effectiveness in terms of how they develop the recommendations. Is there a good reason for why we would approach one class of preventive services differently in terms of how we would want to make recommendations that directly shape the insurance coverage that's available to Americans? I can't think of a good reason. Maybe I can be persuaded here today if we think about it. The broader question to think about is, knowing some of the anxieties and concerns about cost effectiveness generally, is even if we think it's an important thing, and we might commend the ACIP for being sensitive to it, does it make sense for, again, one entity to do it independent of the ACA requirements while we know about the waste and inefficiency and misuse and unnecessary healthcare resources that are spent in our $3 trillion healthcare system in the U.S. here? Is it a laudable self-restraint on the part of our champions of vaccines to think cautiously, but does it have the effect that it intends if the vaccine folks are the only ones doing it? Third point on this, and then I'll move to the next case. Even if we think it's a good thing, we think it's a model for how the health system could work, I think there are fair questions to say that, are we overly complicating the important technical work, the complicated, necessary expertise required to take what we know about childhood vaccines and adult vaccines and generate the best evidence-based recommendations, just how to use them independent of cost, right? That's important work to begin with. Questions about then, is it worth spending? How do we make those choices are important policy questions. They require different kinds of expertise necessarily than questions about how we can evaluate clinical trials and epidemiological data and figure out how to make the best schedule to use our vaccine toolkit most effectively. So the questions about, even if we want to pursue this, does it serve the children who can benefit from vaccines and the other groups who can benefit from vaccines best, for these questions to be handled here? And does it serve those who benefit from vaccine-preventable disease prevention vaccines? Does it serve to benefit those groups to have this structure compared to groups who benefit from other preventive interventions? Those are questions I want to think about for part one as we move forward. Part two. So these recommendations that I spoke about come from the federal government. They're endorsed and developed in tandem with the pediatricians groups and the family practitioner groups and the OBGYNs, but often sort of wave the CDC federal banner. But then we turn to the question about state requirements, state vaccine requirements, aka mandates, a term that I take some issue with that we'll talk a little bit about as we go along here. This is familiar, I suspect, to this crowd, a little bit about school entry requirements. These are state or local policies, as the federal government makes clear. It has very little to do and very little to say about how states think about school entry requirements in American states. In the District of Columbia, for public school or daycare, private schools may or may not be included directly in these requirements, but most tend to follow something that mirrors their states. And the logic is simple, of course: vaccinated, or you can't attend school, unless, of course, and I'll come to this in part three, unless you receive one of these tricky exemptions for medical, not so tricky, or non-medical reasons. And even people who have exemptions can be excluded in outbreaks. These are state-level policies. Again, for the most part, cities sometimes tweak them slightly in terms of doses and things like that. But if you look sort of broadly, just where requirements exist across the 50 states and DC, you see a fair amount of uniformity here. That most of the vaccines, these are all things that have been recommended prior to 2000, are more or less required in virtually every state. There's some sort of quirks here that the mumps vaccine is not required in a few places, but in the U.S. you can only get the mumps vaccine with measles, mumps, rubella, so these people are covered anyway. So some odd historical quirks here. And on the right are the vaccines that have been added to the routine recommended schedule since 2000, and it takes some time. That's sort of my point in this talk, for requirements to roll out. So you're seeing some slow introductions, some influenza. This is merging daycare requirements and school requirements. But you see these newer vaccines and influenza as we now promote it more routinely for kids. More places thinking about requirements for school and for daycare. But it's HPV I want to talk about in our time together today. So we've got, as you know, 2 vaccines in the United States against human papillomavirus. The Gardasil product accounts for about 99% of the market. For lots of reasons. It was first, it protects against the broader strains in cervix. It's approved for both genders. There's now a newer, more improved version of Gardasil that's being rolled out that will even, how much more you can dominate a market than 99%, but will promise to do that. And I think for good reasons in terms of the benefits to both young men and young women. But the story, it's getting it was new when I first started talking about it, but it's getting a little, old now. These questions around vaccines when they were first introduced, particularly when Gardasil was first licensed in 2006. It was not a smooth rollout, and it continues, I would say, not to be the smoothest rollout in terms of building support for HPV vaccination, building vaccination rates. And there were these theories around concerns around vaccinating young women first, and then young women and young men against the sexually transmitted infection. There were these conclusively refuted allegations that vaccinating young women and young men would lead to changes in sexual risk-taking that were implausible when the vaccines were approved, and have been conclusively refuted now that we have years of data vaccination coverage. There are concerns around corporate lobbying on the part of Merck for the foremost in terms of what they were doing to try and build support for vaccines. And a lot of this came to a head in really the first year of the vaccine's life, Gardasil's life, which had a few-year head start, by the efforts in almost, I think, about 36 states to introduce requirements for the HPV vaccine for 6th grade girls, the only group for whom it was approved at the time, to receive the HPV vaccine as a condition of school attendance. The most notable example was Governor Rick Perry in Texas who passed an executive order in January 2007, and he was overwhelmingly overturned by his state legislature, almost unanimously through both houses there. So it was not a smooth launch for HPV vaccines for any stretch. I think part of what we're seeing, and advocates of HPV vaccines have been seeing, is an attempt to sort of turn the page, and it's taken a while to turn the page on these narratives about anxieties, about the value, the necessity, the risks and benefits of the vaccine. So these stories about mandatory vaccination, of course you have your usual range of perspectives, people who think vaccines should never be required, people who believe, the sort of classic parental autonomy type arguments, and those are common to HPV, they're common to any vaccine, but I think they were less interesting at the time that these first debates were happening than comments like these two. And Alan Hinton and Walt Ornstein, if you're a vaccine person in the room, you know these names. These are guys who spent their lives at CDC and then out of CDC as vaccine champions here. These are people who believe in vaccines, they believe in the importance of school entry requirements, but at the time that a lot of this was brewing up in 2007, their comments were saying, whoa, not so fast actually here. That yes, requirements are great, this vaccine is great, but it's a lot more complicated than just saying, even if you take the most charitable view, that we know requirements help boost vaccination rates, we want to boost vaccination rates, ergo let's require the vaccine. That something's missing if policymakers are following that logic as a way to promote the vaccine, even if you don't want to get into the corporate lobbying and those sorts of things. So Alan Hinton noted the fact that how it really did sort of poison the discussion about educating about the vaccine, educating about the disease it prevents. Walt Ornstein said again, it's well-meaning, but people didn't understand the complexities that go into a mandate. At the same time, the state immunization managers, these are the people in the 50 states and DC and elsewhere that are in charge of making immunization programs work in their municipalities and jurisdictions, issued a statement that sort of endorsed that same logic. It said, let's think about requirements, when we use them, when they become in order, time-wise, what kind of things should happen before we start talking seriously about mandates. It said there's an appropriate implementation period, whatever that means, where we think about financing. We get all those financing details in place, make sure we have a way to pay for it for people who have get vaccines through public programs or private programs. We think about supply issues. Can we make it millions of doses at a time rather than what we would see in the early stages of research or the early stages of implementation? Do we have good safety data? Have we educated the public and providers about the vaccine and the disease it prevents? These things take some time, and it's important to work gradually before a requirement then builds on that foundation and helps sort of push vaccination rates to the levels we see. That's what they're endorsing. It's kind of the view from Hinton and Ornstein and others there. So where are we now? So we're now 8 or 9 years later. in HPV vaccination in the United States. This is the most recent data from CDC that came out about a month ago. And the rates are still disappointing, right? They're still disappointing. They're climbing slowly for females. There's a slightly larger increase year to year for young men for the 3-dose series, and of course they're higher for partial series, but well below the healthy people 2020 targets, and certainly well below what we would expect for a vaccine that's been around now as long as Gardasil's been around in the United States. So over the last year or two, there has been a concerted effort to reframe how we talk about, how we think about HPV vaccines. And you'll see these notes being hit again and again by people in government, by out of government, saying, this is not a vaccine against a sexually transmitted infection, this is a vaccine against cancer. Let's try and reverse that narrative. And the other one, this is what I want to talk about, is that we should think about, we, physicians, providers, everyone, should think about HPV vaccination in the same way that we think about vaccination against any routinely recommended vaccine. That we shouldn't single it out when physicians and providers are talking to parents. They shouldn't say, oh, okay, it's time to talk about HPV vaccines. We know you might have heard a lot, but I want to sort of explain what the concerns are. That sends the message that this is something to be worried about or something that should be treated differently. The idea is, my phrase, but I think it captures it, no HPV vaccine exceptionalism. That say, when the adolescents come in, it's time for the Tdap, it's time for the first dose of the meningococcal vaccine, and it's time to start the HPV vaccine series. And we know that there are kids coming in getting the first two, but not getting the third. So treat HPV like any other routine vaccine, capitalize on those missed opportunities, don't flag that there's something contested or controversial about it, and that will go a long way, is the message we hear. And we've got a litany of government reports from the President's Cancer Panel, again, picking up on this theme here, an NCI group, private groups like the National Foundation for Infectious Diseases picking up on these themes. The CDC director has done the same thing. Treat it like any other vaccine, emphasize the cancer prevention elements. So we were interested over the last year in sort of looking at how those two stories fit together. When mandates become in order, when it becomes time to talk about mandates, and how does that fit with the let's treat HPV vaccine like any other routinely recommended vaccine? So we said, all right, we're about 8 years now since the recommendation was published in MMWR, making it official. You know, what can we learn from these other experiences, at least in a crude sense in terms of months and years, for when other vaccines that were things that we care about for adolescent vaccinations, that are included in this NIST study, either because they're adolescent vaccines or we care about immunization rates against things like Hep B or varicella that we hope kids are vaccinated against much earlier. Where were they at this point in their histories with respect to school entry requirements? That's basically the question that we just wanted to get some sense of whether this HPV story is exceptional in this other sense that people don't seem to be talking about. What are mandates looking like now? So this is what we found. We looked at Hep B and varicella and the meningococcal conjugate vaccine and HPV. And the key is, unlike HPV, many states have some form of requirements for some group. Adolescents, school age, college in the case of the meningococcal conjugate. The requirements are robust for these other three vaccines for groups for whom they're recommended. And even, okay, you know, Hep B's vaccine's been around for 24 years now, but even if we turn back the clock and we figured out, all right, when did the requirement first take effect? Even 8 years after the recommendation, many more states were requiring these other comparable vaccines, for lack of a better word, than where we are now with HPV vaccine 8 years after its introduction. We have these requirements in Washington, D.C. and Virginia that are sort of requirements in name only. The exemption procedures are so gigantic, it's hard to even call them requirements. And we just had in Rhode Island a requirement that took effect this school year. It's the first one in years where they're phasing in a vaccine requirement for HPV. So, again, there might be reasons, despite this emphasis on let's treat HPV vaccine like any other vaccine-preventable disease, there might be reasons why state health officials are not following their own seemingly sensible advice. Surely there's some anxiety about, I suspect, going down this road again. Rhode Island has faced some pushback. They were able to do it through rulemaking action, so it didn't have to get through the state legislature and signed by the governor, and that reduces the barriers to getting a requirement through, and many states can do that. But it's notable, I think, to say, okay, if we think that requirements have lots of benefits, and one of them, as I'll say in a minute, is the fact that a requirement signals a degree of importance and familiarity to a vaccine sort of independent of its enforcement and legal standing, which is another view of advocates of vaccine requirements. Well, then not having requirements for HPV at this point might seem to go against that message to say that this vaccine is every bit as important as the other ones. It's not different, it's not murky, pardon the pun, it doesn't need to be treated differently than other vaccines. So it's a notable difference. What it means for how we think about who's at risk for HPV-related diseases versus other vaccine-preventable diseases, I think is worth thinking about. I think requirements, as complicated as they might be to go down that road again, given the baggage and the long memory of how it impeded the efforts of introduction of the vaccine 8-9 years ago, might complement the existing efforts to normalize how we think and talk about the vaccine. That's part two. Part three, in my last 10 minutes or so before we go to questions, looks at an issue getting a lot of attention. The first two, not so much. The third one, just in January this week, is this paper from Tony Yang and George Mason and others that are looking at, all right, here we are now, we've had the measles outbreak, and he and his co-authors looked at all of the action that's been going on in state houses over the last 7 months or so that would do things to how we structure our vaccine requirements. Either eliminate them, as happened in California, eliminate non-medical exemptions, as I should say, exemptions for either reasons of religious or personal beliefs. Many states are considering, some have passed, many have not, efforts to restrict vaccine exemptions. That's what I'm going to talk about. And then there's some other ones that will expand mandates, and some others that would even create vaccine exemptions in states, mainly from conservative legislators, that haven't passed. So we have this landscape, as this map notes, recently updated now to reflect California, where every state but West Virginia, Mississippi, and now California allows some combination of exemptions from state vaccine requirements for non-medical reasons, and sometimes distinguishing between whether it's a religious reason that an exemption can be granted or a personal belief can be very difficult to do. So the folks at the Immunization Action Coalition did their best. But the key are these three states where a medical reason is the only valid grounds for children to be exempted from those requirements to be vaccinated as a condition of school attendance. So there are strong, interesting, principled reasons why we might talk about eliminating vaccine exemptions altogether. You can probably make them there in terms of the community benefits, in terms of the benefits to vulnerable children, the benefits that come through vaccines that shouldn't be overridden by a parent's religious or personal views. We could talk through those arguments at length, but it's this area that seems to have the most momentum, restricting exemptions, preserving them but making them harder to get. Seem to have the most momentum maybe because it's more feasible, it's seen as a compromise solution. Also, it's seen as perhaps a way to avoid concerns about a backlash that many advocates of vaccines believe would follow an effort to eliminate exemptions entirely. We'll see whether this happens in California. This is the best statement I've seen in print. Many other people in the vaccine world who agree with Ed Marcuse here from the University of Washington, who would compare eliminating non-medical exemptions, who compares it to prohibition. So there's a concern about backlash. It could really do more harm than good here. And he, like many others in this camp, argued that if we think about a personal belief exemption policy that explains the risks that that choice comes with, that might create some administrative burdens so that it's not simply done out of convenience or ignorance, that's the more prudent, as his title suggests, way to proceed, that would do more good for the overall health of a national vaccination program than this take it or leave it. This is in the best interest of your child, and we will enforce this as best we can. And enforcement is another challenge if we think about eliminating non-medical exemptions. I just saw this on the train down here this morning. Vermont was one of those states here that I noted has eliminated its philosophical exemption but kept its religious exemption. And the AP noted that the Vermonters may find religion, because one of the challenges is that you really can't, it's very hard to enforce the sincerity of one's religious beliefs. So they note here that Vermont's one of the more secular states here, but parents who might have concerns about vaccines all of a sudden will say, it's not my personal belief that's fulfilling that, it's my religious belief. And that is a challenging enforcement challenge. It's a challenging challenge for states who are thinking about these religious exemptions. So, restrict but not eliminate is what I want to talk about. Again, our friends at the Association of Immunization Managers have another statement that endorses this idea to strengthen their regulations to ensure that exemptions are only available after education and acknowledgement of the risk. So they're not calling for eliminating exemptions, as the AMA in a statement over the summer endorsed, but they're calling for this restriction, this middle ground approach. And really what they're targeting are policies like this in my state home state as of a month ago. So this, you can go to the Connecticut Department of Public Health website if you believe you have a religious exemption or you want a religious exemption. You download this form, you fill out the name of your kid, you sign it, and by signing it, you're asserting that the immunization would be contrary to the religious beliefs of your child. And you're on your merry way. These mandates that people get so worked up about autonomy and the public good and individual rights, is as simple as going to your handy public health website, downloading a form, and mailing it in. These are concerns of vaccination advocates that say we need to do better than this. And some states do better. So New Jersey, for example, at least makes you write a letter. You have to write in your own words why vaccinating your child goes against your religious beliefs. But again, if you're a savvy web browser and you go to the state health department website, you'll see guidance from the Attorney General of New Jersey to the school districts that enforce these requirements, and say, because of First Amendment reasons, I've added the emphasis, that as long as this letter says religion or religious, the statement has to be accepted. So if you live in New Jersey and you can use religion in a sentence, these requirements that we get all worked up about are requirements in name only. But still, this is better, it's seen as better than at least having to sign a form. At least you have to know the magic word and you have to write it in your own hand. Some states, the people who classify these things and look at exemption rates, some states do better still. This is New York. They require that they give state officials the authority to assess whether beliefs are genuine and sincere. They might require supporting documents. They might require exemption requests to be submitted annually or notarized, or little things like that make a difference in making vaccine exemptions administratively harder to get, but then seem, as I'll show in a minute, to have a positive effect in reducing the number of non-medical exemptions as we move from easy, medium, to difficult exemption processes. And in New York, they can call you in, they can help, the state officials can have an interview or a conversation, but fear not, again, savvy internet people, there are services available in New York State that for a fee will coach you on how to write your letter, will coach you on how to work with state officials in terms of how not to fail this sincerity hearing that would happen here. You can see here, again, alone you're a nut, together we're a tree is the motto of this group. This is a service here that will help you. So if you know who to look for, you have the time and the resources, these processes, even in their most difficult form, can be navigated. So I argue that calling these policies mandates is sort of a misnomer, except in West Virginia, Mississippi, and California. They sure seem a lot more like opt-out policies to me, where there are some administrative steps, some cases harder than others, to not have to comply with the vaccine requirements, but in many cases, getting the exemption is easier, certainly, in the easy states, than actually fully vaccinating your child, or even fully documenting that you fully vaccinated your child, and that's seen as a real weakness in these policies. So they're easy to obtain, and I think this is a point I first heard from Doug Beekema, who's coming here later this year, a while ago, who noted that, if we're thinking about compulsion and opt-outs and all that, there's an opportunity here for some sort of alternative service, for lack of a better word, to avoid the free rider problem of children who are not vaccinated, who are trying to benefit, often not successfully, parents who are trying their children to benefit from these policies. Maybe there could be some sort of tax, some sort of contribution to public health programs, some way in which there is a shared sacrifice coming if these policies were to work like compulsory military service, if that's the idea that we're thinking about here. But nevertheless, all right, so I pointed out these flaws. These policies have issues with them. They're still viewed as essential. You can't get anyone who lives and dies with the success of the vaccination program to argue that these policies, despite their flaws, are worse than not having them at all. One of the reasons is, as I mentioned with HPV, that it can signal that vaccines matter. It adds an extra oomph to efforts at the state and local level to try and get vaccination rates up when there's a mandate as part of it. It has these harder to quantify benefits. But how well do we know that? How well does the public know that in general? We've got data when we look at the vaccine hesitancy world in these last couple minutes, and we compare it to who gets exemptions. We know, this is a few years old now, but I think it still more or less holds, that we know that anxieties around vaccines are widespread, far larger than the number of parents who don't vaccinate their kids. You see these percentages what's interesting from other studies is that parents who have anxieties about vaccines don't actually fit any obvious socioeconomic, income-based, or education profile. That the anxiety about vaccines actually crosses those lines. But then, you say, wait, I don't know that. But then you look at who gets the non-medical exemptions. That's the story we hear more often. Who actually follows through with the non-medical exemptions? Then we have studies like that we've heard. More likely to be white, well-educated, higher income, well-educated, higher income areas, children in private schools. The trends, the stories, the narratives that we hear from these studies, we go and we study these communities, and we get this narrative that says, okay, we have a broad base of parents who have anxieties about vaccines, but when it comes time to successfully obtaining the non-medical exemption, we see a far different story, a far more homogeneous story in terms of what the exemptors look like here. So, big numbers of anxieties, the actual results in terms of who is opting out, much smaller, 2%, but the trend is growing. The trend is higher in states that have those easy exemption policies, as the researchers have sorted them. As the difficulty of an exemption gets higher, the exemption rate goes down. All right, so how do we tell these two stories about hesitancy and then how it follows through to non-medical exemptions? It could be the fact that people who follow through with exemptions really are those with the most sincere objections, right? That's the premise of these recent efforts to make exemptions harder to get, is to say that if we just really make it harder by notarizing it and doing it annually and making you sign a statement and acknowledge the risks, that it will sort of weed out the people who are doing it out of convenience or ignorance or some combination. It will just leave the most fervent opponents of vaccines, and we're willing, if we accept this position, to sort of accept that for the greater good of healthier vaccination programs. Or it could be, what seems to concern me, that it's actually who's savvy enough to know the magic word, to what to write on the letter, who knows who to hire to get help with the exemption procedure, who has the time, the resources, the money to work through these administrative requirements to get to the desired goal. And we shouldn't be encouraged when we look at the groups who have the non-medical exemptions right now, because they would seem to fit, at least in a broad sense, that pattern. We need more data to look at this for sure, but if we made vaccine exemptions harder to get, in this sort of model, we preserve them, but we make them harder to get. If there is something like this going on here, we would only exacerbate it. So that's my concern on this front, is that we don't want to end up in a two-tier system where it's an opt-out. It's really an opt-out policy for people who have the time and resources and savvy to navigate it, but it's something much closer to true compulsion for those among us who do not. So that's that third point of fairness. I think I'm at 1 o'clock, so I'll hold off on the sort of the summary type comments. Think about these three together. Think about, again, how these policies affect not just identifiable individuals, but the individuals we can't identify who stand to benefit from vaccines or from other preventive interventions, and how we think about how we treat these individuals as a consequence of our policies. So I'll end there. Thank you for your time and look forward to talking a bit.
Field your own questions?
Sure, please.
Thanks, that was great. I just wanted to follow up. I noted to my colleague Ann here that California, Mississippi, and West Virginia is interesting to try at. Lump them together, and I'm wondering if you have any, thoughts, or if there's been any work on why those three ended up this way.
Yeah, so Mississippi, it goes back, and forgive me, I don't remember the history as well as I should. Mississippi and West Virginia have been like this for a long while. So that's the interesting thing, is that the other shades had changed a lot as policies came and went, but West Virginia and Mississippi were the stalwarts in terms of not allowing them for decades. And Mississippi's the one I know best. Goes back to a state Supreme Court decision in the 1970s, which basically argued on constitutional terms that there wasn't a right to opt out of vaccination, tracing it back to sort of classic public health powers law. This was a state court, interpreting the federal constitution. The federal courts have not responded affirmatively that exemptions need to be granted. What has happened, and that's what we see reflected in New Jersey, is that you're going to permit personal belief exemptions or religious exemptions. You can't be wading in to have your minister sign this letter or cite the scriptural verse that informs your vaccine requirements. All of those sorts of clauses have been struck away by the courts. So we see that happening nationally, but Mississippi have the state, it could have killed it at many times along the way. So it frankly showed how hard it was to get these policies passed, and people are now watching it eagerly to see if these concerns that people had worried about in terms of a backlash, in terms of also medical providers in California. There is still this medical exemption, the same sort of loophole. Michelle Mellor wrote about this in the New England Journal about a month ago. Well, medical providers doesn't say which kind of healthcare providers you need to be. Will there be people who all of a sudden are signing off on medical exemptions of any or all takers? Because then that's another giant loophole if you can, if providers are complying with that. There are plenty out there who are willing to accommodate a variety of views about vaccines and no vaccines at all. So we'll see. This is a real-time experiment to see how that plays out. They are interesting. It is an odd sort of triad of political sensibilities, to say the least. Please, give me the mic.
I want to flip what you just said on its head and ask you to respond to the physicians who are refusing to take care of patients whose families will not vaccinate them. And is that an unintended consequence in the implications of that?
Yeah, so this idea that, in colloquial terms, doctors firing patients is the idea here. And the argument for it is that providers care. So the vaccines are so important to a provider that what better way to send a message to parents and families and protect all the patients in a practice than to say, this is what I believe about vaccines. I'm not a physician, but if I were, this is what I believe. And if I'm going to be your patient, or your child's patient, your child's provider rather, this is my view. And if you have an alternate view, I'd encourage your provider, your child and family to seek someone else as their healthcare provider. And that has elicited a range of views, as it sounds like you know. The American Academy of Pediatrics has been reticent about going down that take it or leave it, tough love road in all of the most extreme circumstances. That's what their policy statement, again, that Doug Giacomo wrote, and they've reaffirmed recently, that would say that that's actually, that might close off opportunities for discussion and conversation. That it's a good thing if a family still wants to see a physician who is strongly in support of vaccines. There's an opportunity there. And if you say, no, take it or leave it from the start of the relationship with the family, then off those families go. They go to these doctors. You can find these listed online again, the vaccine-friendly physicians, they're called euphemistically, where anything you want, anything you don't want, space them out, skip them, whatever you want, off you go. And then the question is, what happens to the advocacy for those kids? And so I'm sympathetic, and I think on balance, I think the AAP's view is the right one, to say that if there are times where there's just a breakdown between the family and the provider where you're not providing good care for the kid in general, that's something. But the idea that this is my stand, it does sort of it runs the risk of leaving kids high and dry, and that worries me about that if it became sort of a widespread practice.
Thanks, Jason. Great talk. Is this on?
Turn it on.
I can also try.
Sure.
I can do that.
Can give you mine too.
Do we need to have it mic'd? I think
No,
we're
you're fine.
Okay. I have two questions, and thanks. I have two questions, and you can answer both or one, whichever you prefer. So I was interested in the argument from one of the articles you presented that this could be like prohibition, right? That if we really have a very strong requirement, then the movement against vaccination goes underground. Given how old the stricter requirements are in Mississippi and West Virginia, this seems like an empirical question rather than just a claim, and I would love to know if there's any truth to that. My other question, which maybe relates a bit more to the title of your talk, you presented here in the end these important arguments about equity, that instead of a lot of families, everyone getting the exemption, now the families with more resources are. And obviously inequity is always an ethical problem, but at the same time, there are actually still more families getting vaccinated. So I'd love your take on if you had to do a trade-off where you would fall and if there's a third option.
In terms of the exemption and the restricted case. Yes, the first one, so the West Virginia, Mississippi, you're right, we have long periods of time to see how this has played out in these states, and we haven't seen revolts, we haven't seen families, we don't hear at least, of families moving across state lines to vaccinate their kids. So the question would be, okay, well actually maybe these worries of a backlash or more harm than good arguments are overblown. Two questions, right? So two things to trace about that. One is the fact that West Virginia and Mississippi are probably not generalizable to the rest of the country in terms of their size, in terms of the other measures we look at, in terms of government resources, and the questions around enforcement. Because that's the other issue that sometimes gets lost in this discussion. We talk about these mandates, take it or leave it, child vaccinated, they can't attend school, but enforcement and compliance is a real challenge as well. The mandates and exemption policy we have only works if there's a broad foundation of support for people who don't need to be tracked down or nagged or to get them in full compliance here. That you've got that strong groundswell, because a lot of this falls to school districts where, especially in big cities, budgets are non-existent. It used to fall to school nurses, which are dying off around the country tragically, or to state health departments. These are not places that are flush with resources and extra staff to direct to keeping track of records and cards and nagging parents and making sure that the kid's not showing up at school. So the other question is that if you undermine sort of that strong foundation of support or complicate it, the enforcement burden, the compliance burden, as they sometimes talk about it, becomes unmanageable. And that might be the question. That might, I bet if we had in Marcuse here to talk about it, that would be the concern as well here, that it would become unsustainable in terms of how we do it. That was the first one. The second one, the middle ground question. I think I have been a believer in restricting the non-medical exemptions as a middle ground, as a prudent middle ground approach. The one way in which, I don't think it's Marcuse, but others have talked about the eliminating requirements is that's a pressure release valve, is that it does allow, if we think about the vaccination system as a pressure cooker, that allowing some number of parents to opt out, if it's the truest or true believers, it takes pressure off the entire vaccination system. And you do the trade-off to say, okay, these kids are now at greatly increased risk, but it allows the rest of the vaccination system to survive. And so I think the compromise view about restricting exemptions has been a way to try and balance these competing aims here. And if we can do it in a way that does it fairly, which would mean, I think, healthcare providers and public health officials don't want to publicize their exemption procedures. You have to hunt to find them. You have to hunt to find the details, but they're out there. But if we think there is a middle ground position that allows for requirements and exemptions to coexist in a way that does the best for kids and does the best for communities, I think we would have here as people are in good faith trying to balance these aims. Ruth?
Yeah. Very nice comment. Thanks, Jason. So I have a comment and a question.
Sure.
And as you can imagine, around ACI
Sure,
and cost effectiveness. So I would
They
say...
weren't happy with me when we wrote that cost effectiveness up there. There was a conference call from Atlanta who were a little concerned about what we said about cost effectiveness, which aligned with this one.
Yeah, so I guess the comment I wanted to make is that I do think ACIQ members share some of your concerns around cost effectiveness determinations, in part because while we are supposed to take cost effectiveness into consideration, there aren't particular guidelines for how we're supposed to take that into consideration along with all the other evidence that's presented to us. And I think it's a particular issue now with ACA because the nature of whether we recommend something permissibly, as you know, or we say that something should be used, the consequences are the same. They have to be covered by insurance, and while that doesn't present equity issues, which is a really good thing that it doesn't, it does present cost issues. So things have sort of been turned on their heads, and it's an interesting time. My question is, do you think there are other countries that do it better, and who are they? Because there are other countries where cost effectiveness is specifically addressed by a separate committee.
Yeah, so on the first point, I wanted to mention this, that shortly after the ACA was passed, veterans of the Preventive Services Task Force published a perspective, a viewpoint in JAMA saying, separate the direct line between preventive services A or B recommendation and the covered requirements. They said that the Preventive Services Task Force is engaged in important scientific, evidence-based work in terms of assessing the quality of evidence about the interventions they review, and that needs to be separate from the policy level discussions to say, here's all the things that work real well, where do we then invest scarce health resources? We know that if we're covering everything that's a preventive intervention coverage for the things they're not required to cover, or change cost sharing. So there are changes happening as a result of these requirements. And that Preventive Services Task Force recommendation, I think, was right. There's important work to be done in evaluating evidence. There's important work to be done in then saying, how do we then prioritize what we believe is the foremost kinds of interventions. And I think something like that for the ACIPs is, as Adam Mahmoud and I wrote up in the New England Journal, there's something to be said there for separating those two sets of very complicated tasks and thinking that it's more systematic about how we weigh cost effectiveness. Do we weigh, these core questions about cost effectiveness analyses, do we weigh, do we add more weight to interventions that are life-saving, more interventions for children, more things to prevent severe disability, which we know public attitudes tend to value higher, all things being equal, than the sort of quality of the quality monitor. So there are interesting questions there that you guys are sort of asked to be sensitive to, but not necessarily, guide in terms of how it shapes what you do. On the other groups that do it better front, so the UK example with NICE and their vaccine component, JCVI, I think the story around the meningitis B vaccines is an interesting one, right? So they recommended that these new meningitis serogroup B vaccines be administered to all infants. We don't vaccinate infants against any type of meningococcal disease, which is another story that people I know have strong views about there. There are certainly benefits that could be gained, but for all sorts of reasons we focus on vaccinating adolescents. But the UK folks recommended using these new meningitis B vaccines for infants, but because they have these formal and relatively rigid targets in terms of cost, there was a stalemate between the National Health Service and, first it was Novartis, now it's GSK, in terms of at what price there'd be a contract to make this vaccine available. And really the National Health Service won. They were able to get a price that was about 7 times what we're paying here in the United States, and 7 times what the manufacturer originally offered. So it's down to $20 a dose in the US, and it's well over 100, right, something like that, in the United States there. So that's an example of where it can do some good. You could extract the benefit and also then have some leverage